Hello, everyone, and welcome to this webinar, Terminologies and Classifications, SNOMED CT-AU and ICD-10-AM use in Australia. My name is Aileen De La Pena, and I'm a product support specialist with the terminology team at the Australian Digital Health Agency. So as we get started, I'd like to acknowledge the traditional custodians of the lands that we are meeting on or dialing from today. For me, it's Gadigal land, belonging to Eora Nation people. I'd like to acknowledge their connection to country, sea, and community, and I'd like to pay my respects to elders past, present, and emerging, and extend this respect to any Aboriginal or Torres Strait Islanders joining us today. So just some housekeeping, as everyone is still popping on. Everyone is on mute, but feel free to type in questions at any time in the questions chat box and we'll answer them at the end. We should have some time, maybe about 15 minutes at the end for questions. This session is also being recorded and we'll let you know when it is available for viewing. So now I'll introduce the presenters. We've got three today. So Pan Teng is the product support lead for clinical terminology in the agency. The agency is responsible for national digital health services and systems and delivery of the National Digital Health Strategy and its implementation. The National Clinical Terminology Service, or NCTS, as a division of the agency, operates as the Australian National Release Centre for SNOMED International to facilitate and support the correct use of national terminologies in Australia. Laura Harris is the Director of Classifications at the Independent Hospital Pricing Authority. The Pricing Authority determines the national efficient price and national efficient cost for activity-based funding, or ABF, in public hospital services and block-funded services. It also specifies all the classification, costing, data and modelling standards that are required for ABF. And lastly, Vicky Bennett is the unit head for My Health Record Data, Metadata and Meteor units at the Australian Institute of Health and Welfare. The Institute produces authoritative and accessible information and statistics to inform and support better policy and service delivery decisions. They run various national data collections, develop and improve performance indicators and targets for national agreements, and develop and maintain national metadata standards housed in Meteor. So with that, I will now hand over to Pan to start the presentation.
Thank you, Aileen, and good afternoon, everyone. Just in terms of the session today, a few learning objectives for today's webinar. So we'll give you some examples of the various code sets that are used in health. We will describe for you the purpose of clinical terminology such as SNOMED CT-AU. We'll describe the purposes of health classifications, in particular ICD-10-AM. We will compare the features of SNOMED CT-AU and ICD-10-AM. We'll also inform you about the ICD revision, so ICD-11, and also finish off with talking about a bit of the maps, what's available for you between SNOMED CT and ICD-10. So why would we record clinical data electronically? So the way that we have delivered medicine and medical practice has changed over time. We need more and more access to data that is electronically recorded so we can perform some analytics on that data. Historically, clinicians have relied on their own clinical knowledge and experience, so they had little to no data requirements. Then we started to move to predictive medicine, where clinicians accessed other clinicians' knowledge so they can better identify patients' risk of developing the disease. We then moved to evidence-based practice, where gold standards for treatments are developed, and this requires access to high levels of data. So we are now in the era of personalized or precision medicine. So for example, genomics and biomarkers, where we need access to the highest level of data to help develop optimal therapy for individual patients. So why use standard vocabulary? So once we've got structured internal data based on a standard vocabulary that can be easily shared amongst clinicians and systems, we can start to gain actionable insights. So we can do simple counts based on some clinical characteristics like the number of patients that have diabetes with hypertension, for example, or maybe patients with diabetes with sleep apnea. We can also do a bit more complex predictions of disease for patients based on risk factors, such as smoking, obesity, and excessive sugar intake. And finally, we can do sophisticated analysis at the population level to find trends, hidden patterns, perhaps unknown correlations. And this is where big data analytics come in. Just give me 1 second, I'll just have a look at the audio.
Okay, so let's talk about an overview of the code sets used in health. So there are different types of code sets as you can imagine that's used in healthcare. And classifications like ICD-10 organizes concepts into categories or groups based on common characteristics. So Laura and Vicky will talk to you a little bit later on around ICD-10-AM and classifications. So clinical terminologies like SNOMED CT includes concepts in multiple levels of granularity. So they also hold machine readable properties of concepts. And then there are other code sets that are regulatory in nature or enable standardization across the health systems, such as the PBS and the Australian Register of Therapeutic Goods. So this is just an illustration of some of the most commonly used health code sets, classifications, and ontologies in Australia and also around the world. So it is only illustrative in nature and not meant to be exhaustive. So it's just an example there. So I guess these code sets provide content for major clinical domains that we have. So ranging from diseases, procedures, lab tests, medicines, devices, and anatomy. So I've colored ICD-10-AM and AIHPA in red in the circle there, and I've also colored SNOMED CT-AU in blue. So unsurprisingly, many code sets exist in the domain of diseases and their signs and symptoms. Examples of this would include classifications like ICD-10-AM, ICNP, and ICF. Then you have the genomic-specific code sets like HPO and OMIM. In the procedures and intervention space, we have things like AIHPA, ICPC2+, and MBS. You would see that some code sets span across a few domains, like the ICNP, which spans across diseases, clinical situations, family histories, procedures, and also anatomy. In the laboratory space, we have LOINC. In the medications and substances space, we have the PBS, ATC, KEBI, and Orphanet. And devices, we have things like GMDN. And finally, SNOMED CT-AU includes content for all these major clinical domains, and also some other smaller domains like organisms, units and measures, and qualifiers. This slide, I guess, is meant to show you what the different code sets used in health are really used for their intended primary use cases. So healthcare resource groups, HRGs, and diagnosis-related groups, or DRGs, are classifications that standardizes prospective payments to hospitals. I guess it's also known as case mix funding. Laura will talk a little bit more about AR-DRGs as part of ABF funding later. DRGs are fairly small. They have hundreds of concepts or groups and are stable. Classifications like ICD-10 are much larger and covers tens of thousands of concepts. They're typically used for statistical data analysis and reporting. Again, Laura and Vicky will talk a little bit more detail after this. Clinical terminologies at the bottom there, like SNOMED CT, are used to record direct patient care and therefore have hundreds of thousands of concepts to cover all clinical domains. SNOMED CT-AU, that is the Australian extension, has just under 500,000 concepts. It is also dynamic in the sense that new or changed content is added progressively as human medical knowledge advances. So I'll give you a little bit of an overview around clinical terminology now. So what are clinical terminologies? So one of the main features of terminologies is that they enable sharing of clinical information between systems, systems in between intra settings as well as inter settings between different settings, without the loss of detail or meaning. So thereby this enables semantic interoperability between systems. So you don't I guess it's like working as a universal code set that spans across different systems. So people still have can still have their own different primary code sets in those different systems. So why would you use clinical terminology? So clinical terminologies will support different systems, tools, apps used in healthcare where we need computable data. So as long as you need coded and structured data across different multiple systems, it provides a foundation for successfully delivering and realizing benefits of many of the national digital health strategic priorities that have been outlined as part of the Australian Digital Health Agency's National Digital Health Strategy. In fact, the Digital Health Strategy is not owned just by the agency. It is actually owned by all sectors within healthcare. In terms of the specific priorities that the National Digital Health Strategy that clinical terminologists will support, there's 4 named priorities. So priority 1 is My Health Record, so where health information is available whenever and wherever it is needed. Priority 3, which is interoperability and data quality. So this is where high quality data with a commonly understood meaning can be used with confidence. Priority 4, which is medicine safety. So this is where better availability and access to prescriptions and medicines information. And priority 5, which is enhanced models of care. So this is where digitally enabled models of care can drive improved accessibility, quality, safety, and efficiency. So SNOMED CT is the preferred national solution for clinical terminologies and has been endorsed by AMAC, the Australian Health Ministers Advisory Council. SNOMED CT-AU in particular is the Australian edition of SNOMED CT. So it contains all of the SNOMED CT core or international content plus Australian specific content. So the Australian specific content includes the Australian Medicines Terminology or AMT, and that's just the medicines extension for Australia. We have other Australian specific stuff like the Australian dialect reference set and a whole lot of different subsets that have been, I guess, created to support common use cases. And then there's also emerging FHIR value sets. So these are the different FHIR-enabled ways to actually access clinical terminology. SNOMED CT-AU is used across all healthcare sectors in Australia at the moment, so including things like general practice, the community settings, allied health, obviously the hospital settings within child health, EDs, inpatient, etc. It is released monthly at the moment to all license holders. So when should we use clinical terminology? There are 3 main, I guess, primary use cases or scenarios where you would use a clinical terminology. The first one is where you want structured and coded clinical data to be captured at the point of care. Second one is where you want to share that captured coded information, clinical information between systems, again, intra as well as inter systems, inter settings. The third one is around where you want to start to have meaning-based retrieval of that coded information and then doing some data analytics on the clinical information. So around the first use case, structured and coded clinical data capture, this is where you want to record information about a patient's healthcare encounter at the point of care within some clinical information system or electronic health record. So this allows SNOMED allows clinicians to record what they need. So really, with the actual content coverage, the broad content coverage that we have, as well as the specific concepts that drill down to the correct level of detail that they may need. And also, SNOMED also allows each concept to be found using multiple descriptions. So we have basically different synonyms or different names that belong to a particular concept, and these all can be searched in the user interface to bring back the same concept. So in terms of this particular slide, this is a simple patient record with some SNOMED CT-AU encoding. This is illustrative only. So we have a problem list with chronic otitis media and asthma as problems coded there. Under allergy, we have a shellfish allergy. Under test request, we have a lipid panel concept there. And then Canicum otic and Ventolin inhalation powder for as current medications. In this particular example, the SNOMED CT-AU terms are displayed to the clinician, but upon recording, the SNOMED concept identifiers are recorded in the backend. So sharing of clinical information is your next primary use case of SNOMED, and this really allows standard terminology across multiple systems. Unambiguous concept identification is also key, obviously, to support this particular use case. And because the concept, because each SNOMED concept identifier in the middle there, which is malignant tumor of kidney, and you would see the SNOMED identifier there on top, the series of characters there. Multiple names or synonyms can be given to this particular concept. So, for example, malignant tumor of kidney, or it could be renal cancer, renal malignant tumor, or CA renal, all will bring back this particular concept when recorded. And so synonyms really cater for local language preferences and enable flexible term searching on the user interface. Around the third specific use case for SNOMED CT is the support of meaning-based retrieval and analytics. So the structure of SNOMED CT supports flexible retrieval of clinical information really for analyzing and reporting purposes. So a subject can be retrieved via many pathways or different properties. So the pathways, as you can see on the right-hand side there, for viral pneumonia is really to say that any records encoded with viral pneumonia can be retrieved when you start from any of the higher level concepts. So you could search, for example, pulmonary disease. You can search for it via infection. You can also search for viral pneumonia through inflammatory disorder or any of the different I guess, higher level parentage and ancestors of viral pneumonia that you can see on the right-hand side. On top of that, SNOMED CT concepts are represented by precise and machine-readable definitions that really is there to enable a rich data set for analysis. So what it means that subjects can be found based on common defining attributes. So in this particular example, you can a query for infectious processes in the lung will return records containing viral pneumonia as well as pulmonary tuberculosis because both of these concepts have the finding site, have the same finding site and the pathological process machine readable meaning and encoded within SNOMED. So you can actually search on both these characteristics to find these two particular concepts plus others. So in terms of meaning-based retrieval and analytics within SNOMED, you can actually use a language called expression constraint language or ECL. Now, ECL is just a specific language that has been created and developed by SNOMED CT, and it allows easier searching for SNOMED CT using, I guess, the machine-readable structure and the attributes that were found that we talked about in the last slide. So you've got descendants or ancestors and parents and children and things like that, or search through membership of ref sets or reference sets or subsets, etc. So static and dynamic queries can be formulated to retrieve any type of data, as long as, I guess, you are searching through by selecting any number of available machine readable attributes. The ECL tool is available in the CSIRO Shrimp Terminology browser. So if you go into that link, there will be a portion on the right-hand side there, on the top right-hand menu. If you click on ECL, you'll find some more information to actually help you create the ECL queries.
Thanks, Pan. So in this section, myself and Vicky will cover what a health classification is, why and when a health classification would be used, and how health classifications assist with statistics, management of health services, and activity-based funding of public hospitals in Australia. A health classification is a structured and a standardised way of organising information into groupings for statistical reporting. There are sets of rules, both nationally and internationally, for the collection and coding of data to ensure these groupings are consistent and accurate. A good example is, once a patient is discharged from an acute inpatient stay at hospital, the diagnoses and interventions that occurred during the patient's stay are translated from the medical record into alphanumeric codes within the ICD-10-AM for diagnoses and AIHPA for interventions, classification systems. Classification systems in health enable professionals such as health information managers to use data to support decisions and policy development. Classifications also enable research, analysis of large data sets, and identification of public health trends, as well as providing information on patient case mix for activity-based funding. So why would you use a health classification? A health classification would be used to identify patterns and trends in data, and therefore is an optimal tool for statistical reporting. Using a health classification for statistical reporting enables better evidence-based decision-making and optimal management of the healthcare system. This is achieved by health classifications providing a consistent method of reporting conditions, treatments, and their associated costs. In healthcare, the use of classification support easy storage, retrieval, and analysis of health information, the comparison of health information between hospitals, regions, settings, and countries, as well as data comparison within the same location across different time periods. Also, classifications are used to measure hospital and health service provider output. So a good example of a health classification is the Australian Refined Diagnostic Related Group, or the AR-DRG classification, which is used for admitted acute hospital care. This is a complex classification which is underpinned by three core components, which include disease, intervention, and standards. The classification used to capture information on disease is ICD-10-AM, and the classification used to capture information on interventions is AIHPA, and these together are underpinned by the Australian coding standards. The ICD-10-AM classification is an expanded version of the World Health Organization's ICD-10, which has been modified for use in Australia to classify the cause of death. So health classification should be used for three primary purposes. The first would be for immediate and longitudinal data management and retrieval across different groups. The second would be statistical reporting of clinical activity and other health information such as disease or intervention. And the third would be measuring service provision, including patient case mix and activity-based funding. So I'm just going to pass on to Vicky now, who'll further discuss the ICD classification and its use in measuring potentially preventable hospitalizations.
Thanks, Laura. I guess, as Laura's mentioned, classifications are used for both morbidity and mortality reporting and analysis in Australia, and indeed globally. The ABS does most of our mortality disease mortality classification, and the AIHW, where I work, does a lot of the reporting on that. And this slide just shows us how we are able to use that ICD codes for death certification classification. And one of the really important things about being able to use the ICD is our international comparability. So obviously this little graph here shows us some underlying cause of diseases, cause of death by sex in 2017. And it's critical that we're able to do this not only at a national level, but internationally. And as you can imagine, the implementation of COVID death certification has been a really important addition, and being able to compare those things globally has really been important in the last few months. So the other really important measure, and particularly that is used extensively in Australia, obviously at a facility level, it's really important to have coded data. But one of the very important uses of our morbidity data is to be able to compare facilities, states, and nationally across a range of performance measures, safety and quality measures, many kinds of metrics that actually help us manage and monitor our health system better. And potentially preventable hospitalizations is just one example here. This makes reference to the 9th edition, which is not current, but the measuring of potentially preventable hospitalizations has been ongoing for many years now. You'll be able to see there's a reference to Meteor link there under the 3rd dot point, and the definitions for how to measure these things are available in our Meteor, which is our online metadata product. But classifications are definitely a very important way for us to manage and monitor the health system, and this is just one of those good examples here across a range of conditions there that we know that should potentially not require hospitalisation if well managed in the community. I'm going to pass back now. Thanks.
Thanks, Vicky. So I guess health classifications optimise the management of healthcare services by various different things, and these include measuring patient case mix, volume, complexity and trends to support managerial decision making to ensure high quality healthcare, quality and safety of health services, policy development and accurate allocation of activity-based funding to public hospitals within Australia. In terms of classifications for activity-based funding, there is a number of different classification systems that we use for the different types of care that's provided at public hospitals, and you can see that outlined on the table on the slide. For admitted care, the ICD-10-AM, ACHI and AR-DRG classification systems are used. The Australian National Subacute and Non-Acute Patient Classification is used to classify subacute and non-acute care. The Australian Mental Health Care Classification is used to classify mental health care. The URG, so the Urgency Related Group, the UDG, the Urgency Disposition Group, and the AECC, also known as the Australian Emergency Care Classification Systems, are used for emergency care. Tier 2 classification is used for non-admitted care, and the Australian Teaching and Training Classification is used for health professional and trainee classification. So on the bottom half of the table, you can see that each classification utilises various different measures to accurately group patients. So for example, the AR-DRG classification uses routinely collected data or variables such as age, sex, motor separation, and length of stay. It also uses newborn admission weight for newborn babies and hours of mechanical ventilation for some patients that are in the ICU, in addition to disease and intervention-based information. So I'm just going to pass back to Pan now, who will discuss SNOMED and ICD-10-AM a little bit further.
Thank you, Laura. So this particular few slides will talk about how SNOMED CT-AU and ICD-10-AM can support specific use cases. So I guess SNOMED CT and ICD-10 really, as Laura and Vicky and I presented earlier on before, they're really designed for their intended primary use cases. So they're really good for supporting what they're really used for and developed for. So SNOMED CT-AU really is for clinical data capture and retrieval. As we said, there's a polyhierarchy or multiple parentage or multiple ancestry happening with SNOMED data, and items really are defined that through many pathways. You can be retrieved through many pathways or machine readable properties that belong to each of the concepts. So really it's there for precise and unambiguous definitions that are then machine readable for analytics and reporting afterwards. Now ICD-10-AM really is to support statistical aggregation and reporting, and it's really good at doing that. So items are organized with non-overlapping categories based on their properties. So a single hierarchy generally, but no subject belongs to multiple classes, so they are distinct. And also it is complete and includes a category for everything, or other buckets such as not elsewhere classified or unclassified. So in terms of supporting data capture and clinical communication, so specificity and content coverage are important considerations when you start to select the standard code system for data capture. And also these are really important when you start to communicate with other systems, not just the actual recording in your input system. So SNOMED CT has been designed to for primary data capture in clinical information systems or electronic health records. It contains sufficient detail to allow clinicians to record the information they need, and the meaning is retained when transferred between systems. So in the actual image that you see there, we are somebody typed in vascular myelopathy, but because there are more detailed concepts that are available or connected to vascular myelopathy, you could potentially then select infarction of spinal cord if that's what you want. In terms of ICD-10-AM, when you select a diagnosis, the image on the right-hand side, they have, I guess, less or limited values to capture that specific clinical detail because the broad groupings represent one dimension of meaning, but a single code does group multiple clinical meanings. So G95.1 vascular myelopathies actually includes acute infarction of spinal cord, hematomyelia, edema of spinal cord, and subacute necrotic myelopathy. In terms of supporting clinical data analytics, so once data has been captured in a structured way, it can then be meaningfully analyzed. So SNOMED CT coded health records, sorry, the type of questions that can be asked then of the data and what the results will return to you. It will depend on the codes that you are working with. Both terminology and classifications will support analytics at different levels of specificity. So SNOMED, because clinicians input SNOMED into individual health records at the primary collection of data point, it enables the analysis of that particular patient data, so that's available to you. But in the secondary use of data, SNOMED coded records can also support this particular area, but it's really only it's for the clinical data that has been coded with SNOMED for things like clinical cohort analysis, prognosis, decision support, and patient care exchanges. Health information managers, though, in this secondary use of data, this is where ICD-10 and ACHI come into the fore, where health information managers will use the whole healthcare record to code episodes to that, to those classifications, which then enable analysis of aggregated data in predefined categories. So This particular slide really very quickly kind of talks to you about clinical data analytics and what's kind of possible in terms of clinical analytics using SNOMED. So we can define categories using the ECL, expression constraint language, identify some records with SNOMED codes matching some certain criteria. So this is really trying to look at opioid usage defined by sex for males and females. And really, we use the SNOMED codes to filter a particular clinical data set to get a particular result. So this is a med-specific example. So in terms of supporting statistical reporting and aggregation, in terms of a particular use case, ICD-10-AM categories are broad and distinct. And so this really allows a single counting of an instance and meaningful population health analysis. So because this is the main use case, and it is well developed to actually support this. So I guess in the tables and the diagrams kind of try to show how this counting is meaningful, and there's no I guess double counting happening. In terms of SNOMED CT, for statistical reporting aggregation, it is not going to be as straightforward as ICD-10-AM for statistical uses. And this is because precisely because of the polyhierarchy or the multiple ancestry that we talked about for SNOMED concepts, where many things are linked to many other things as machine readable links. So in SNOMED CT, it's not as straightforward because you can get double counting if you don't actually put in some strategies in place to avoid that same disease, for example, being counted twice or multiple times in a single category. So there are, if you want to use SNOMED for this particular purpose, extra strategies need to put in place, and you have to put in place some extra business rules and in your queries. And I will hand back to Laura. Oh no, for Vicky.
Thanks, Ben. So up until this time in this presentation, we've been talking about ICD-10 when we've talked about the International Classification of Diseases. This little section just talks about what's coming in the future. So ICD-11 was released by the World Health Organization in 2018 and adopted for use by member states in May 19. And as you can see there, no decision's been made as to when and how it will be used in Australia at this stage. However, we have been working a bit in that space, both at the AIHW and within other committees. I guess ICD-11, one of the value cases of that is it does actually provide a wider scope of services. So it's designed not only to cover morbidity and hospital-based, mortality and hospital-based morbidity, it actually is designed to be able to be used across all healthcare service settings, things like general practice and so on, which allows us to have more consistent data collection across the health system. It also has a new digital format, which allows it to be embedded within health ICT infrastructure more readily. It includes new clinical concepts that have become, obviously, as advances in clinical practice have changed and understanding of clinical conditions, and has got rid of some very unhelpful old terminology that people complain about in the current version. And it does bring an increased opportunity as countries adopt it for expanded international comparison. So at the moment, countries generally only provide WHO mortality data. Some morbidity data goes to organisations like the OECD, but the idea of having ICD-11 used for morbidity more generally and allowing comparability between countries is something that is part of the plan for ICD-11. And just to note that we are collaborating with SNOMED, WHO is collaborating with SNOMED on the development and mappings between the two. So this next slide does talk about some of the features. It is certainly an expanded list of codes compared to 10 and 10-AM. It has a lot more functionality related to, as I said, areas, health settings like primary care, morbidity, mortality, activity-based funding. And just as a side note, there is some international work on an international plan for an activity-based funding classification, but that is sort of still in development. It again will have an updating process that is designed to be done globally rather than having local classifications developed like we have had for 10-AM and 10-CA in Canada and 10-CM in America. It is designed to be able to be used globally without a local modification. I guess there's some debate about how that might happen or whether that'll be good enough for us, but wait and see what happens there. The AIHW where I work is actually a WHO collaborating centre for ICD, so we are the Australian Collaborating Centre for that. And as part of that, we have undertaken a bit of a review of ICD-11 in the year before last and last year in the plan to help us be better informed about how to make a decision about if and when to go ahead with implementation of ICD-11. The ICD-11 review stakeholder consultation report was published on the 12th of May. So that is available on the AIHW website. And if anyone needs a link to that, I'm sure I can provide it later. But it did show that there is limited knowledge, obviously, in Australia about ICD-11, and that we do need to do quite a bit more work to inform relevant decision makers. The last dot point there is largely out of date now because we have no COAG, therefore we have no RMAC. So it did go to the last RMAC meeting last year that has endorsed that we do go ahead with planning, but how we progress those things without RMAC and the subordinate committees, there will be some decisions yet to be made. So we have consulted with our Australian Health Classifications Advisory Committee on some ways forward here, a bit of a review about how it could be used in Australia. And the Independent Hospital Pricing Authority is also doing some thinking in this space, how we might put a roadmap together for how we can use classifications and terminologies together going forward. We need to do some, what's the value proposition of ICD-11 planning, certainly in the morbidity context. Concurrently, the ABS is working on some mortality implementation plans for ICD-11. For those of you who have not heard of it, because ICD-11 has taken the sort of lead at this stage, the WHO has been developing an international classification of health interventions, which is similar to our Australian classification of health interventions, and the Australian Collaborating Centre participants in Australia have actually been working very closely with WHO on the development of the ICHI. It has a much broader remit than even our ACHI has, which was originally designed on the MBS classification. It has a very expanded use case in public health, primary care, health interventions and functioning. Late last year and early this year, we had a number of Australian coders participate in a beta 2 field testing of the ICHI, which has been done globally. I think we, as a country, did the second most second highest number of coded case studies and line coding globally. The AIHW is preparing a report on that field testing that we'll be able to disseminate and publish for the Australian context. But largely it's been seen that the ICHE has covered a lot of improvement, I guess, across not only admitted services in the use of classifications, but the potential for the ability to be able to use a classification that ranged across all health settings into the future that would allow international comparability again. Certainly, again, no decision around what sort of timeframes, if or when we would implement ICHE in Australia, but it's certainly a development that we would like to continue to collaborate internationally with and potentially do some further field testing for the Australian environment. So that's all I've got to say about the sort of ICD-11 and the developments, but if anyone has any further interest in that, please feel free to contact me later. Thanks.
Thank you, Vicky. So this particular section now talks to you about what sort of maps are available between SNOMED CT and ICD-10. So I guess it's really important to stress that SNOMED CT and ICD-10 have complementary strengths. And really around SNOMED for capture of clinical information, decision support, communication, analysis, clinical research. ICD-10, as Vicky and Laura has detailed before. So I guess maps are just links, formal links between different code systems. And really, it is important to stress that mapping is not a simple task, a one-off exercise, or low risk and low cost approach. So in terms of mapping tables, there are actually mapping tables between different editions of ICD-10-AM, different editions of ICD-10-AM to ICD-10. But in between SNOMED and ICD-10, there is a map at the international level, so international edition of SNOMED CT from SNOMED CT to ICD-10. So that direction is really important from SNOMED to ICD-10. The technical guide is actually available there if you click on that link. But again, it's important to stress that it is actually just to ICD-10, which is the international edition, not the Australian modification. There is, however, locally in Australia, there are actually two maps available for you, and they're both from the Australian eHealth Research Centre of the CSIRO. So the first one would be the SNO map for ABF, specific for ABF funding. This particular map enables diagnosis recorded using SNOMED CT-AU, so Australian concepts, the Australian edition within emergency departments that can be converted to ICD-10-AM codes for non-admitted patient reporting. The other one is SNOMED starter map. This is a brand new map, and really there's a few more slides after this. I'll talk a little bit more about that, but it's really for research and analytics only. And this particular starter map maps from SNOMED CT-AU to ICD-10-AM 11th edition. And then finally, there are also other mapping tools that can actually be made available. It is actually available to you, which is also from the CSIRO, called Snapper Map. So these are slides from the CSIRO, courtesy of the CSIRO. So the SNOMED starter map is a web-based mapping tool that utilizes their terminology server platform called Onto Server, and it provides mappings between defined terminologies. This particular map, it provides a starter map from SNOMED AU to ICD-10-AM 11th edition, and it really requires, the map requires application to data. So different application rules will exist if you have different data sets, naturally. It is really only for research and analytics only, and it requires an understanding of SNOMED CT-AU structure as well as ICD-10-AM rules. This particular map is available as a file concept map resource. It it's really important to note that this particular map does not support mandatory reporting for NMDS and as well as case mix funding, which, as I said before, that particular SNOMED for ABF map is a separate map to this SNOMED starter. It is not to be used in any user-facing or point-of-care deployments, and really that the SNOMED for ABF deployments is optimized for ABF purposes only. And this SNOMED starter map is available under subscription, and we believe the CSIRO will make this available from August 2020, very, very soon. And so for more information, please contact Donna, Robin, and Kate from the CSIRO. Okay, so I'm just going to very quickly summarize, I guess, today at a glance, really, SNOMED CT-AU and ICD-10-AM or ARCHI, while the sizes are different, the scopes are really quite different, obviously, cover all major clinical domains within SNOMED, but diseases and health-related problems and interventions for ICD-10-AM and ARCHI. SNOMED really is to be used within health records and CISs, clinical information systems, and ICD-10-AM ARCHI really for within patient administration systems, national minimum data sets, for example, and clinical registries. And importantly, it's applied by clinicians for SNOMED and applied by health information workforce for ICD-10-AM and ARCHI. So some highlights, I guess, to put the terminology and classifications in context together. We're really there to, Terminologies is there to support primary collection of input of clinical information. We want to enable patient care management through decision support and exchange of that information. We want to enable effective retrieval and reuse of that information for clinical analyses. Classifications like ICD-10-AM really is there for statistical reporting for clinical activity and other health information, and really used for one big use case is really for activity-based funding in Australia. So I guess using clinical terminologies and classifications together for their intended primary purposes really is it should be your what you should be thinking about. The intended primary purposes are different. So if you want to think about clinical inputs, communications, or statistical outputs and reporting, and really using the two together really enhances and strengthens clinical and patient information use, as well as decision making and also clinical outcomes.
Thank you. So there was a lot of information there. Thank you to our presenters. We do have a couple of questions that have come through. So one question from Philip is that IHPA has released an app to help refine diagnoses using ICD-10 content. And is there a plan to re-release this using SNOMED? I think I'll throw to Laura first for a comment around what this app is, and then followed by Pan to talk more about whether this will be released as part of SNOMED.
Thanks, Eileen, and thanks, Philip, for the question. I guess in brief, not at this point. IHPA's Right at Right app is an educational tool which is used to support clinicians in driving improvement in clinical documentation within Australia. The app itself prompts when a user should move from general to specific terminology, which is drawn from ICD-10-AM classification and the Australian coding standards to support mandatory reporting. So I might just pass on to Pan to sort of bring SNOMED into context.
Yeah, look, Philip, we need to have more talks with IHPA around this, more detailed discussions. But then, as Laura was saying, it's really going from general to specific, whereas generally from SNOMED to ICD, it will go from specific to more general. That is the direction from SNOMED to ICD, and that's the general direction, moving from terminologies to classifications, only because of the content specificity and granularity from SNOMED needs to go to a less granular classification. Otherwise, the other direction would just be very unwieldy. It pretty much goes into there's going to be too many target concepts if we go in the other direction. And that's why, in general, the maps will, you will see any maps between SNOMED to ICD, whether it's international or localized within Australia, the direction is very specific from SNOMED, which is more specific, to ICD, which is less specific. But what we can do is we can report back to you once we have spoken to IHPA about this app. And we will make a point to get back to you, Philip.
All right, thanks for that. I'm conscious of time, so I think we'll just answer one more question. And so this is from Anna. What are your thoughts on the Department of Health's requirement for electronic prescribing to have a free text field option for reason for prescribe in addition to capturing SNOMED CT-AU value? So Pan, would you be able to speak to that?
Yes, thank you, Anna. So in terms of the electronic prescribing, the terminology requirements for the electronic prescribing program of work, we are looking to actually present a few webinars to the industry, to prescribing and dispensing vendors shortly. So we are in the motions of putting that into our calendar. So keep a lookout for that. It's probably going to come in the next month or so, next month or two. And so we will actually, I guess, talk about some of those specific requirements there very, very quickly, though. I think the SNOMED CT-AU will be mandated for reason for prescribe in the next conformance profile version. And so in terms of having an additional free text field in addition to the SNOMED encoded value, I'll have to look into that and see what the main reason was from that project to have that. I feel that it's probably would have been put there to potentially augment concepts that are missing within SNOMED that needs to be added, for example, or you can actually add more contextual information to that particular reason for prescribed value that you record within SNOMED. So we will get back to you on that, and also I'm sure we'll include that within the webinar, our electronic prescribing webinars, to answer that.
All right, thanks, Pan. So we have run out of time today. We will take some of these other questions on notice. And of course, if you have any additional questions, you can contact us via our help centre, help@digitalhealth.gov.au, and we will send them to the right people for answering. So, so that wraps up our session today. Thank you to our presenters, Pan, Laura, and Vicky, for their time today. Just as when you leave, there will be some survey questions, so please take a minute to respond and give us your feedback. It's really useful for us in planning these sessions. And you will also get an email, a follow-up email in the next day or so with links to where to download the slides. And finally, thank you all for attending this webinar and enjoy the rest of your day. Bye, everyone.